afternoon, and welcome to Global Health Intelligence's webinar on the impact of COVID-19 on Latin America's healthcare system. First and foremost, we hope that you and your loved ones are keeping safe, healthy, and resilient during these difficult times. My name is Mariana Romero Roy. I am GHI's Director of Business Development and Intelligence, and I will be your moderator today. We will begin by quickly going over our legal notice, which I encourage all of you to read on your own time. What we're stating here basically is that everything that we discussed during this webinar is based on our research and on our viewpoint. Most importantly, we also want you to keep in mind that as things are changing on a daily basis, what we discussed today might or might not be as valid next week as it is today. I also want to give you a little bit of background information on the company. Global Health Intelligence was founded in 2014. However, we have more than 20 years experience conducting market research and market intelligence across the region. This has enabled us, as you can see on screen, to come up with very unique services and each year come up with great publications, which have been crucial for everyone doing business across the region in the healthcare industry. Moving on, we have great panelists with us today. First, Guillaume Corpart, founder and CEO of Global Health Intelligence. Dr. Cynthia LeRouge, associate professor at Florida International University. And Gustavo Menéndez, managing director of digital transformation and telemedicine at Cisco. Now, in terms of the structure of today's webinar, we will begin by seeing where Latin America stands in the global context in terms of COVID-19 and the impact of this pandemic. We will then see and analyze the penetration and positioning of telemedicine in Latin America. Then we'll see what are the next steps in telemedicine after COVID-19. Lastly, we will have a Q&A session at the end of the webinar. For this purpose, I ask all of you to browse the lower part of your screen. You should see a Q&A button. Please go ahead and click on it and send us all the questions that you have throughout the webinar. At the end, we will do our best to answer all of them. Just so you know, we will also be sending you this presentation in more or less 24 hours. Lastly, we have 4 poll questions throughout the webinar for which I'll be popping back on to guide you through. And as a matter of fact, we will now begin the webinar with our first poll question. Thank you. In your opinion, what are the biggest challenges to telemedicine adoption in Latin America? Technological preparedness, lack of political backing, financial model and incentives for providers and insurers, lack of decision and full understanding of telemedicine implications on behalf of key stakeholders such as payers, administrators, physicians, patients, etc., or cultural constraints. Now, this is a tough one. I believe that we could say all of the above, but let's wait and see what everyone thinks on this. It's funny, actually 2 days ago, I was discussing this with a client of mine, and he was actually telling me that he believes that cultural constraints are in fact one of the biggest challenges, as many Latin Americans and people in emerging markets in general don't trust technology when it comes to healthcare and thus need that extra little bit of human contact with the doctor. That's what they're used to in Latin America. So to tell them that now it's going to be through a computer or through a cell phone or through a screen in general is challenging and actually very frightening for many people. So very interesting to see that. All right, the answers are back. We have the results. So 60% of you think that it's lack of decision and full understanding of telemedicine implications on behalf of key stakeholders. Very interesting, followed by cultural constraints, as I expected, and the financial model and incentives for providers. Very quickly, I just want to let you know that as I expected, all of these answers, we have between 32 and 60%, and all of them have their certain weight for this question. So thank you everyone for participating. And without further ado, let's see how or where Latin America stands in the global context with COVID-19. Guillaume?
Great. Thank you, Mariana, and thank you everyone for joining us here today. I want to give a particular thanks to both Cynthia and Gustavo, who are taking time out of their very busy schedules these days in order to be with us here today and discuss telemedicine in Latin America. Now, if we move on to the first slide, when we look at the hospital market on a global level, we see that there's approximately 100,000 institutions worldwide. Approximately 1/4 of these institutions are in developed economies such as the United States, Europe, Canada, Australia, Japan, and others. And China, in and of itself, also accounts for almost 1/4 of the world's hospitals, nearly 23,000 institutions. Now, a third quarter of the world's hospitals are in Latin America. Latin America is very rich in terms of the hospital infrastructure. We account for nearly 22,000 hospitals. And if we dress a list of the top 10 emerging markets by number of hospitals, we see that 4 of these countries are in Latin America, specifically Brazil, Mexico, Colombia, and Argentina. Next slide, please. So Latin America has a vast hospital infrastructure, as I was saying, nearly 22,000 hospitals. We're also talking about nearly 1 million hospital beds and 50,000 operating rooms. However, there's a stark contrast between hospitals in Latin America and those in other regions around the world, specifically in the United States or Europe. Hospitals in the US and Europe typically have approximately 160 to 165 beds per institution. Whereas in Latin America, we see that the average hospital has approximately 46 beds. So much smaller in size, approximately 1/3 of the size. And this is further exasperated between the public and the private systems of Latin America, where we see that private institutions tend to be much smaller than their public system counterparts. And nowhere is this more evident than in Mexico, where we see that private institutions have on average approximately 13 beds, whereas the public institutions of Mexico have over 100 beds. So what does this mean in the context of COVID-19, and what does it mean in the context of telemedicine specifically? Well, firstly, that the hospital market in Latin America is much more fragmented than in other regions around the world, where we have many more smaller players in terms of the healthcare space. Okay. Furthermore, we see that there's very few hospitals, or there are fewer hospitals that have the capacity to be really centers of expertise where specialists might reside and that can act as telemedicine hubs in this case. Yet there's many more hospitals that can really act as spoke sites, and we're going to get into those concepts of hub and spoke in just a few moments. We also see that that many hospitals, given their smaller size, don't have access to the same financial capabilities and the same financial tools in order to invest in capital-intensive technologies and capital-intensive equipment. Okay, so the financial constraints on that point really need to be customized and are really unique in Latin America and not necessarily seen in other places around the world. So solutions providers really need to adapt their offering in order to meet the uniqueness of the Latin American market. Next slide, please. Here, the graph on the left, what we're seeing is the number of COVID cases that are reported globally. And about a month ago, what we were seeing is an exponential growth curve, really a hockey stick movement in that regard. And that has very much leveled off over the past couple of weeks, where we see much more linear growth. Now, the challenges that we're facing around the world, and particularly in Latin America, is the limited capacity of our hospital infrastructure and our hospital caring systems in order to treat patients with COVID-19. This is why social distancing is so important, and that's why so much emphasis has been placed on social distancing over the past few weeks. It's really there to flatten the curve, and that's something that we've heard many people say over the past couple of weeks. And it's there really in order to ease pressure that's being put and placed on the healthcare systems today. So if we look at the graph on the right-hand side, the finite capacity, when that's dictated by the orange horizontal line that we see here, really defines how many patients we can treat. And with a flatter curve scenario, we can treat many more patients than we can in a peak curve situation, exemplified here by the pale blue line and the black line. But regardless of the shape of the curve, we're putting a lot of stress today on our healthcare systems, much more than we have in the past. In fact, I don't think that at any point in time have our healthcare systems been under so much pressure and so much stress. Let's move on to the next slide, please. Now, across Latin America, countries have adopted social distancing measures at varying times and at very different times. In this case, Argentina, Chile, and Colombia were very much early adopters of social distancing at an early stage. And therefore, we can see that their curves in terms of the impact of the reported cases so far is much flatter than those of other countries. In contrast, Brazil and Mexico are very much laggards in the adoption of social distancing. And we're seeing that they're experiencing much greater peaks and much more stress on their healthcare system than the early adopter counterparts. But the reality across all markets, regardless of when social distancing was adopted, is that we're seeing that there's an underreporting of number of cases, and that's true region-wide. And that's due to a series of factors, in fact, a multitude of them. First of all, in many countries around the region, there has been an underestimation of the impact of COVID-19 on the healthcare systems. And so governments were really not ready to conduct the amount of testing that was required in order to make the right decisions. So early, there was a lack of acquisition of the COVID-19 tests and a lack of imports of those in order to distribute across the board. This lack of supply has resulted in the fact that the tests that are available today are given in priority to hospitals where patients go to get tested. And as we all know, there's a lot of folks across Latin America that don't have ready access to hospitals or don't have quick access to the hospital and hospital infrastructure. So they're simply not being tested and they're not being counted in the reported number of cases of COVID-19. Also, when there's cases of people passing away outside of the hospital context, in very few cases are they being tested for COVID-19. And even when they are dying or passing away within the hospital infrastructure and the hospital walls, tests are often not conducted on the deceased in order to determine if they were COVID-19 positive. Last but not least, there's a lot of political pressure that's being put on the healthcare systems in order to underreport and really get the economies activated and started up again across the region. As we all know, there's a very vast number of folks across Latin America that work in the informal sectors of the economy and really live on a day-to-day basis. And so getting those people back to work is very important across the region. From speaking to experts, healthcare experts across Latin America, we estimate that the real number of cases of COVID-19 across the region could be up to 10 or 20 times as many as what's currently being reported by the countries today. Next slide, please. So what does this patient surge really mean for healthcare and for healthcare systems? If we take lessons from other countries, specifically in the case of Italy or Germany that have gone through this and have been going through this for the past couple of weeks, we see that the COVID-19 pandemic really consumes the entire healthcare system. And all the resources of the hospital and the hospital systems and networks really focus 100% on dealing with COVID-19. Also, we see that the public healthcare systems, generally speaking, are not able to cope with the demand and the requirements of the population in this case. Okay? By themselves, the hospital infrastructure is simply not meant for that. So now, what if there was a way to increase the benefits or to complement the flattening of the curve scenario? What else could we do to do that, to increase that capacity in order to possibly increase access to care and drive more efficient healthcare systems in place, at least as it pertains to diagnostics, right? What we'd be really doing in this case is raising the bar of the capacity that we have here. Remember that orange line that we have, that flat orange line, we'd be raising that capacity bar. And I know this is a very polemic discussion and that we were having offline just a moment ago with the panelists. So I'd like to invite you, Cynthia, to maybe comment on this first and tell us what you think as telemedicine pertains to increasing capacity in the context of COVID.
Hi, Guillaume, and hi, everybody. It's great to be here with you today. So I'll comment on this in terms of 4 words that I'll give you. Population, providers, relationship versus encounter, and expectations. What does that mean? Well, we're in a situation right now where every decision that we have to make in terms of healthcare is one where we have to consider the entire population. And that means thinking about things like keeping people safe in terms of the possibility of the communicable nature of COVID. That means that when we can keep them home, keep them in a safe place where there's not chance of transmission, that matters. That's a classic telemedicine type of situation in terms of caring for the whole population as well as caring for the patient. When we think about telemedicine, one good way to think about it is not in lieu of what already exists, but in addition to, and has a backup. And when we have to think of the population, it's very good to help in that way, where we can go to people in their homes. We can also have a situation where we have some very reduced staff, for example, in an ICU ward right now, where we can bring the appropriate type of personnel that for whatever reason can't be there in person, basically that the patient can get some care at that point, some monitoring at that point to alert those that are in place. Providers was the second word. When we look at providers, we also right now have to keep the providers that are providing care, keep them going and do whatever we can to keep them safe and not basically get COVID. So every situation and every encounter, we have to think about their safety also to make sure that they are safe. We also have to think about situations where what if somebody's experiencing something that's not COVID and taking that in-person time for another situation that takes them off the front line of trying to manage COVID. And we also have to think about the nature of the relationship and encounter. It's great to have long-standing relationships with your providers, and that's wonderful. There's also some situations where you need just that quick conversation, what's going on, what's happening right now, the bee sting, the case where it's like, is this a situation or these are symptoms of COVID, to get that quick assessment. And it's not to take away from a relationship you might have with the provider, but get that quicker attention, if you can, from the whatever resource, medical provider resource is available and has the knowledge at that particular point in time. All that said is that this is not necessarily a silver bullet situation. There are limitations in what can be done via distance. So it's setting the appropriate understanding of what those boundaries are and what those situations are and how much can we do in, say, a telemedicine context where a patient's at home and saying, I'm not sure if I have allergies versus COVID, versus when we basically, there's only so much we could do. When we basically have to tell that patient in a triage way, this could be something where you have COVID, we do need you to be tested, and here's how to go about protecting yourself and others around you until we get you to the point and to the place where you could be tested and be cared for.
Terrific. Thank you, Cynthia, for that great insight. I'd like to now invite you, Gustavo, to comment on this, because as we've been seeing in the United States at least, and very likely we're going to be seeing in Latin America also in a few moments, the healthcare system is both under a lot of pressure, but at the same time, a lot of healthcare workers are currently being laid off. So, in your opinion, Gustavo, and from the technology standpoint, can telemedicine really be that bridge in order to articulate the healthcare system a little bit better and supplement some of the limited capacity that we have right now?
Thank you, Guillaume, and good afternoon for everybody. I share with you the same concept. I think it's important to also analyze the capacity in terms of geographic distribution. And I think in Latin America, we have the capacity is heavily concentrated in big cities. So we not only are dealing with a peak in the curve of requirements for the COVID, but we are also dealing with the lack of even distribution of the resources. So we have a lot of resources dedicated in some places, and we have very few resources in other places. And at the same time, we are already canceling most of the procedures and regular visits that were scheduled for this hospital. So what we are doing is I would say, not using properly the capacity we have today. And also we are generating a bottleneck for the future. This is really a problem for the future. So definitely telemedicine can play a role in these two situations to solve these two problems. And we can start putting fast some forms of teleconsultation so that the doctors that are not involved in the front line of the COVID can start taking care of the regular patients that have been postponing their visits and their follow-ups and their also procedures. So I think it's not only a limitation in terms of capacity, it's also a problem of distribution, and currently having people over occupy and some others in the medical system underutilized.
Absolutely, great points. So with that, I'm going to pass it back to Mariana. Mariana, if you could please lead our second poll question of the day.
Yes, thank you, Guillaume. If you could please show up the poll, there it is. In your opinion, what does it take to increase the number of virtual patient visits? Capacity, equipment, motivation and incentives, provider on board, sustainability, or jurisdiction and joint management? Again, a tough one. I believe we can say all of the above, but let's wait and see what you guys think. I just want to take this opportunity. I've had a lot of comments on the language that we chose. We chose English because there's just so many people from so many countries, and I believe it's the easiest language to use. Also remind the people that just joined that you can please send over, you can send over your questions if you go to the Q&A button on the lower part of the screen, and we'll be answering all of your questions at the end of the webinar. So let's give it a few more seconds to get the results. One more second, we're almost there. I know you guys can't see it, but I'm seeing it, and we're getting a lot of info here. So please bear with us a few seconds. And here it is, the results are back. Again, as for the first poll that we have, it's very tough. So we're seeing between 54, 31, 28, and 27%, but most of you think that it is due to motivation and incentives with 54%, followed by equipment with 31%. Thank you again to everyone for participating, and I'll be back for our third poll in a little bit. Guillaume, back to you.
Thank you, Mariana. So in the context of the current presentation, and if we go to the next slide, please. In the context of the current presentation, we refer to telemedicine as the ability to really evaluate, diagnose, and to treat patients at a distance through the use of telecommunications, where the patient is in one location and the specialist is really in another. And this has never been easier for populations across Latin America, where we currently see that smartphone penetration is at over 65%, and we see that internet penetration is at over 60% of the population region-wide. And when we think of telemedicine in Latin America, we often think of interactive medicine, or what we refer to here as interactive medicine, where the physician and the patient communicate in real time through either chat or video chat operations. But other types of telemedicine exist as well, such as remote patient monitoring, where a patient data is relayed back to a certain facility in order to monitor it. And here we could be talking about, information on blood sugar levels, on blood pressure, or even in terms of vital signs in a telemedicine ICU context. Yet a third type of telemedicine that we could be referring to is the store and forward, where health information is stored. So health information from the patient is stored and shared with specialists in order to gather their opinions and diagnostics. So in light of all of this, Cynthia, you and I have spoken many times in the past about the different applications of telemedicine. And maybe you could give us a little bit of comment in terms of what are some of the more basic telemedicine applications that we could see in certain countries, and maybe some of the more advanced telemedicine that you have seen and witnessed in the past.
Mm-hmm. We know a lot of this depends upon how somebody defines basic or even advanced. The biggest thing is where there are situations where you have a maldistribution of supply and demand, where you have a lot of a certain type of expertise in one place and maybe not in another place. What are the also types of things that technology can do for you? So in terms of interactive medicine, you could have something at the level where through private means with appropriate security, where there could be a visit between a patient and also a, say, mental health professional. There's not a lot of extra stuff in terms of equipment and what have you that is needed in that particular type of situation. That can go to a range to having remote surgery, where basically it's not necessarily a communication process, but you're using these tools and what have you at a distance. When you talk about remote patient monitoring, at maybe in some ways considered a more basic perspective, it could be things where somebody has, even these days, to test for certain types of heart conditions. We have heart monitors, things that we send patients to at home, as well as things such as certain types of Bluetooth devices that even pick up things like weight, blood pressure, what have you. We also have a remote patient monitoring, an example that I gave earlier, where somebody is in an intensive care unit and there's a certain number of nurses and providers that are on the floor, and there might be, these are patients that need 24/7 type of monitoring situations, where there could be somebody at a distance that is literally keeping their eye on that patient the whole time that they are in that bed, has the people that are physically there are basically taking care of lots of patients and walking the floor, so to speak. When we look at going forward, even with that, you can have some different ranges of the types of services that are open. It could be anything from teleradiology, and then we're also looking at situations with going forward that it could be telepathology, where we're sending certain pictures of certain types of things that maybe are indicative, for example, of cancer or what have you, that somebody might have a ready conversation and saying, this is what I'm seeing, this is my assessment of this particular situation, or perhaps even somebody having a stroke where imaging and what have you is going to immediately with somebody that's a strokeologist who is not only looking at that image, but also talking to the patient and doing some assessment at this point in time. So in terms of types of medicine and things that can be done, there's a lot of different things that exist out there in the world in each of those areas that you've talked about in a lot of different ways. And I would say even as we think about COVID, it's not just thinking that virtual consumer patient calling or contacting the doctor and saying, I think I have COVID, but in opening up the thoughts of, for all different aspects of care and medicine right now, where can this be a backup? Where can this provide some additional resources that may be needed?
Terrific. Thank you. Thank you so much, Cynthia. And let's move on to the next slide, please. Because as we spoke about earlier, a concept that we alluded to is that of the hub and spoke model and the hub and spoke sites, where really the hub is where the specialist is located and the spoke is where the patient is located. Now, what's kind of fascinating about thinking about this model is that the spoke site can really be anywhere that the patient finds himself. And so it could be another hospital, for instance. It could be a school. It could even be an office. It could be the patient's home. It could be really anywhere where the patient is. And even in certain cases, it could be a correctional facility. And this is really important in the context of COVID-19, because you guys might all remember a few weeks ago when we're talking about the explosion of cases worldwide, there was the case of Iran and the case of COVID-19 in Iranian prisons. So you can just think about how telemedicine can be used to treat a patient that's incarcerated, rather than having to secure their transport out of that facility and onto another site where there might be other folks and cause harm and cause risk, or even possibly just increase the cost of treatment. In this case, telemedicine could be a very apt model to use. What's also fascinating here is the ability for the hub and spoke system to leverage infrastructure, leverage technology and capacity, and to move away from a one specialist to one patient model to a one-to-many, or what's often referred to as the eco model. And Cynthia, maybe you can shed some light on that and some insights here.
So let's look at a situation right now, putting this in a context of COVID, and we could look at something outside of COVID, is in the medical world right now, one thing that providers are seeing is the standard protocols, the standard way they do things, the standard flow sheets, they're changing. They're changing as information is coming out, as insights are found, and workflow routines and what have you are changing on a regular basis. So when we think about a certain type of patients that's being seen right now, it could be that all of a sudden we're seeing some issues that COVID patients have, some challenges with kidney disorders, what have you, is getting that information, getting those changing protocols, getting those people that are seeing certain things, those providers seeing things maybe in advance of my location and what I'm seeing, doing things like an echo model, which is a one-to-many situation where it's one provider, think rounds, like when somebody's in medical school or what have you, one expert that basically is looking at certain patient situations and profiles and broadcasting that out, even though they may be talking about one specific patient, to many, where all of a sudden those particular providers that are out at these spoke sites are getting some real-time learning and insight into what they may be up against and how to treat certain things that they're seeing right now with COVID patients that for them might be one-off, but for somebody that has seen many, many patients and starting to see trends or what have you, they've seen a lot and there are things to share. So it could be that type of situation that we're looking at right now too. So the concept of spoke can be a lot of different things. You know, the spoke might be the patient itself, even looking at something in the home, but a lot of people in the home right now are caregivers and they're caring for somebody in the home. So that spoke might be somebody that you're caring for. That spoke site might be in a telemedicine situation. You're in the car on the way to the hospital and it could be, it's during COVID time, not related, and you basically want to care for this person. It's an emergency situation getting them to the hospital and you don't know what to do. What's the best thing for you to do for that particular person at this particular point in time? So who is, and at that spoke site could be, you know, a patient, it could be other providers that perhaps are not as experienced in a certain way as you are. It could be a caregiver. It could be in your teaching situation. It could be somebody at the school that's setting something up, and even in a not as dramatic and intense time where a child might need speech pathology. And it could be just the setup, somebody sets things up, is there for the child if they have some questions, and then you have a speech pathologist on the other end that's providing that type of service.
Absolutely. Thank you for that insight, then, Cynthia. And something also fascinating here is that a spoke site can also be a hub site, depending on the level of specialization that we're talking about. So if we move on to the next slide, and we look at the benefits of telemedicine, we often group them into three categories in terms of access, in terms of efficiency, and in terms of convenience. And when we talk about access, initially telemedicine was conceived in the 50s and 60s as a way to give care for people that are in very remote locations. Now, given the current context of Latin America, we're talking about a region that has over 70% urbanization rates, and 30% are in rural areas, so certainly could benefit from that. But we're also talking about a region that has mega cities, whether it's Mexico City or Sao Paulo, where transiting from one side of the city to the next could take north of 2 hours. And so distance in that case is not so much measured in kilometers as it is in time. So access to physicians across even a city like Mexico City or Sao Paulo is very important. Access to also the right physicians and enabling scheduling in a much more efficient manner. All that forms part of the access model. When it comes to efficiency, we could be talking about the efficiency of the hospital infrastructure itself. So, when we have areas of public and private systems operating in parallel, how do we get those to interact with one another when there is a patient surge, such as the current pandemic of COVID-19? We could also be talking about the efficiency in terms of costs, where telemedicine consultations can cost, about half as much as a regular doctor visit. Or in the case of faster triage, much more efficient triage system to deal with that surge of patient and tread through them much quicker and much faster, determining who really needs to get that very important test done, that COVID-19 test, and who might just have the common cold. When it comes to convenience, historically, we've always been putting convenience in the context of the patient. So, what's convenient for the patient who might be ill, who might be sick, and so on and so forth. But in the context of COVID-19, that changes a little bit. In this pandemic, we've seen hospitals in New York City, for instance, install tents, triage tents outside of the hospital walls because they simply don't have the capacity inside, or they don't want people that are not sick to walk into the hospital and possibly get sick. And so in this case of convenience, telemedicine plays a really important role because nobody has to go anywhere. Nobody has to be exposed to a harmful pathogen in any of these cases. So with that, I'd like to open up the first question to you, Gustavo, and ask you, what role is Cisco playing in these benefits, in the structure of these benefits in the telemedicine field, specifically in Latin America?
Thank you, Guillaume. I think we can divide this into separate aspects. One definitely is the regular telemedicine adoption and the telemedicine programs that are being laid in Latin America in the long term. And the other one is specifically to the COVID, right? In the COVID, we did have a few urgent offerings that to help our customers. As you mentioned, the tent hospital, for example, is one of them. We have offered the connectivity and all the technology related to the hospital to be placed in the tent and to allow the tent to be part of the hospital as it were something absolutely normal in regular operations. Then we also offer free technology for all our users, clients and not clients. They can access WebEx licenses for having teleconsultations, for having any type of collaborations, meetings between doctors and nurses and different authorities and politicians, so that everybody can work together remotely without needing for meetings and exploiting the potential of WebEx at its most. And then finally, we are also helping with what I mentioned before, with the patients that were being postponed due to the virus and not having their own regular consultations or their regular treatment. So we put together a program for attending these consultations remotely using technology. So this is a very interesting situation today because it's helping all our previous work. We have been working a lot in helping customers to deploy telemedicine programs in Latin America for the last 10 years or even more. And this particular situation is helping to raise and to overcome some of the barriers and some of the difficulties that we found in the past. So this is really a very positive time, and we see this as a great opportunity for the future as well. And again, that's also an opportunity for Cisco to contribute back to the society, to the community in offering free technology, offering free help, which is also part of our corporate social responsibility program.
Terrific, Gustavo, and maybe you can touch upon that just in a little bit about Cisco's help in that, because I see that there's a few questions that have come in regarding and surrounding the cost of implementing a telemedicine program. So maybe we can discuss that in just a moment. But let's turn it over right now back to Cynthia, because I also see a few questions that have come in terms of the type of telemedicine that we currently see implemented in Latin America, which is mainly a teleconsultation. But telemedicine can really go a lot farther than that, above and beyond just the teleconsultation. So Cynthia, can you please give us some insight on that, on the types of telemedicine that are currently being conducted, some of the ones that are maybe less expensive and easier to adopt, and some are a little bit more specialized?
So in actuality, what we tend to see most often is really store and forward. And that's really driven by the world of radiology, where a lot of the reads of the images we take when we go to a doctor are actually done someplace else at a different particular point in time. From there, in terms of the consultation type of situation where there is interaction with the patient, in those types of situations, there's different specialties that come into play that are possible. One of it is that primary care, that general type of scenario, and that's growing, but historically that actually has not been the prevalent type of telemedicine that's done. It's actually been more in the specialty areas where one provider is in the room with a patient, has basically kind of maybe taken things as far as they can, and there's a specialist that can really weigh in on the patient situation and can be part of that exam. So you're in with your doctor right now, and you need a specialist, and there's the communications or telecommunications infrastructure that's available that you can come back for a meeting with your provider and then have a specialist weigh in. And sometimes we have those situations, if anybody's ever been in a hospital, where you're seeing one person and somebody comes into the room that's a specialist in a particular area with a specific type of question. So that's kind of, and in terms of the different specialties that can exist, really telemedicine has been tried in an amazing number of types of specialties. Believe it or not, even something like teledentistry is out there. Dermatology, where we can look at something to see, is this for example, a melanoma cancer from a skin cancer situation, or is it something a lot less severe? So in terms of the different types of telemedicine, if you can think of a type of medicine, there's a possibility it could be taking place in some way, shape, or form, even a part of it, even a little part of it, in terms of a telemedicine type of context. And actually, you know, one of the poll questions earlier was interesting about the understanding and getting it. One of the problems in general with people really kind of getting and understanding telemedicine is it's often talked about in the singular, as if it's one thing. Telemedicine, that's like saying medicine and all forms of medicine are one thing. At the core, telemedicine just means a different mode of delivering medicine that already exists. So if you're seeing a dermatologist, think about seeing that dermatologist or via distance. And again, it comes back to there are certain things that can be done in that situation and certain things that cannot. The dentist situation, obviously there are things that at this point in time in history we don't think can be done via distance, but in other cases that they may be able to be done. So I think that that's a big part of really understanding the benefits, is that we can't think about telemedicine in the singular. We have to look at each potential hub, each potential spoke in Latin America and say, first off, you indicated, Guillaume, that somebody could be both a hub and a spoke. That's true. And it may be because in my particular hospital, I have oncologists, a lot of oncologists that are available to me. And we have a situation that the panels, that they're particularly loaded, what have you, may accommodate some situations. And we may have an opportunity to expand our oncology practice by looking at our supply and figuring out ways that our supply can go to an area that has demand and that has needs. So from a business model perspective, from a benefits perspective, it's not a one thing, but looking at these different parts of telemedicine, these different opportunities we have, and say, is this a right fit for us? And where's the right, if we're a hub in that case, where's the right fit in terms of a spoke? If we have a need in a specific specialty area, we're on the spoke side, where's the right fit of someone in our country or perhaps even another country that can participate to bring that type of specialization into our organization?
Terrific. Thank you, Cynthia, for such a pointed and precise answer. And there was a question a bit earlier about teleophthalmology and what could be done in teleophthalmology. And maybe just as a side personal note, I myself got a teleconsultation about 2 months ago where I had an eye infection. And that was one case where the doctor was able to examine me, and it was very benign, and just prescribe something very quickly and move on. So that's one example that's very personal, but did happen and did come through. So moving on to the next slide. For those of you who don't necessarily know or who don't have as much exposure to our firm as others, every year we conduct a survey of hospitals. And we've been doing this for about 5 years now. And we've talked to about 10,000 hospitals every single year, 10,000 hospitals across Latin America, where we ask them very specific questions about their infrastructure. How many beds, how many equipment, how many machines they have. And one section of that battery of questions is focused specifically on telemedicine. And one of the most fascinating findings that we've come across year over year, again, this is over half of the hospitals of Latin America answer these questions every year, is that telemedicine penetration is 30% higher in the public sector than it is in the private sector. And so a lot of questions came in earlier in the webinar about the segmentation between, or the reality between public and private sectors, wanting to focus on one or the other. But what's fascinating in this case is that telemedicine penetration is considerably higher in the private sector, in the public sector, excuse me, than it is in the private sector. And when we ask respondents why that is, why are there barriers in the private sector for growth of telemedicine, we see that the lack of regulatory framework comes up consistently time and time again. So while telemedicine is widespread region-wide, and certainly in some countries more than others, like Chile, as you can see here, telemedicine is far from reaching its true potential across the region. So Gustavo, I'd like to direct this next question to you is, first of all, are you seeing this from the technology side at Cisco, the difference between the public and the private sector penetration, and some of the barriers that you're seeing in order to increase implementation of telemedicine models across the region?
Yes, definitely, Guillaume. I think there are some reasons, some clear reasons for this situation. One particularly important, I think, is the financial and operational model of telemedicine. The government is in the government, it's a lot easier to implement telemedicine because there is one central budget and there is one central authority. So in terms of allocating resources, allocating doctor time, allocating the different technology resources that are required, it's easy for someone in the government to allocate this and put it to work. This is the case in many of the countries in which we deploy telemedicine programs together with the government. Usually they start small maybe in a specialty, and one of the specialties that we have seen the most is pediatrics, because it's a double specialization. You need to be a doctor for pediatrics, and also you have sub-specializations for different needs, like I would say gastroenterology or cardiology or you name it. So the double specialization favor pediatrics as one of the areas of innovation and telemedicine, and also because the patients are really favorable to use telemedicine, right? But it has, and that's easier for the government because they manage the national pediatrics hospitals, which are centralized, specialized hospitals, and that's similar to other specializations. So we see that the government, in terms of financial and operational capabilities, can do this faster and easier than anybody else in the private sector. That is one. I think the other one is, the lack of specialists that the government is suffering. Remember that government entities cover around 80% of the total population in Latin America. So they've suffered the most in terms of the specialist concentration and the lack of specialists, the gap they have in specialists. So that is one of the areas. The other one is that I think is important to learn here is that the growth or the real penetration of telemedicine in these countries and in the public sector is an ad hoc project. Usually it's not a standard regular way of working, but it's more like a pilot or an ad hoc situation in one specific hospital. And so far, I always said the test of moving to after the 3-digit cases is a tough one. Not many programs in Latin America had overcome 1,000 teleconsultations or 1,000 interactions, and they need to go to the massive scale. They need to move into the thousands and hundreds of thousands. So there's still a long way to go for both private and public sector in terms of telemedicine adoption in Latin America. There is also something important to see when you analyze the Chilean case. First, and as you said before, the regulation is one key barrier or one key element here. And Chile managed to overcome the regulatory situation very fast. They adopted, there was a commission in Congress and led by a doctor. There were a couple of governments that promoted this, and also there was a consultation with the Supreme Court about how to deal with the telemedicine interactions. And they basically supported all the way, and they said there was no need for more specific regulation. So they helped that very much. Then there was another big political decision in Chile, which was the national insurance decided to standardize the teleconsultation and assign a value for reimbursement. So anybody in the public sector could provide telemedicine consultations and was reimbursed by the other parties under the same umbrella of the national insurance. That was another key element here. And there was also a very interesting element that was the earthquake in 2007. The earthquake, many hospitals disappeared. There was a lack of, emergency situations. They were lacking beds, rooms, everything. So telemedicine became one of the national policies at that time, and it helped overcome the emergency and the urgency in the situation. So that was another reason for Chile to go faster than anybody else. And then the other thing is that the government decentralized the implementation. The government, all the government services in healthcare in Chile are divided in districts, right? And the ministry and the national insurance, they provide guidelines, they provide policies and funding, but it's a matter of local implementation for each of the districts to implement it the way they see it appropriate. And while they fulfill the requirements of the policies, they can implement their own way. So that allows many regions to start and do it fast. So these are, I think, lessons learned from the Chilean case that are very helpful and that can be somehow adopted or replicated by other countries.
Terrific, and I think that answers some of the questions that were currently being posed online as to why the Chilean case is so much higher in terms of penetration than other countries in the region. Let's move on to the next.
Sorry,
yeah, go ahead.
Sorry to interrupt, but there is also one comment for the private sector in Chile. You know, Chile has also the most advanced healthcare system in Latin America, and the private institutions have been there for a long time, and they have a combined role of provider and insurer at the same time, and they have developed very, very interesting alliances. So the private sector is also pushing telemedicine really hard in Chile. So the combination of the two is really powerful.
Correct, absolutely. Excellent point. Excellent point. Thank you, Gustavo. So moving on to the next slide, another fascinating finding in our study is that there's a direct correlation between the level of care and telemedicine penetration. So as the hospitals get more specialized, there's a greater penetration of telemedicine. And to answer a question from Lucy online, how do we measure telemedicine penetration? By simply asking the facilities and the hospitals if they conduct some form of telemedicine within their institution. And so however greater the specialization of the hospital is, we see that there's a direct correlation to the telemedicine penetration. That said, in the context of Latin America, we see that over 80% of hospitals are either primary care facilities or general hospitals. And so, you know, it would appear that we would want to put a lot of effort in terms of getting greater adoption of telemedicine, both in primary care facilities as well as general hospitals, in order for them to be able to treat more patients, in the case of COVID-19, to diagnose more patients in a very remote manner, rather than having them come into the facilities. That said, today the telemedicine penetration, primary care and general hospitals, is lower in these facilities than they are in specialized institutions. So Gustavo, since you were just commenting a second ago, can you share with us your view on this, and if you're seeing any initiatives taking place region-wide to grow telemedicine penetration within level 1 or level 2 type facilities?
I think this goes back to the point that we discussed earlier, which is the centralization in Latin America, the centralization of resources. You have most of the specialists concentrated in a couple of places or cities around the country, in one hand. In the other hand, you have these general hospitals that are hospitals, in some cases they are also university hospitals, that used to have all the different specialties, and they are really huge in terms of having a large number of doctors and a large number of medical resources available. So these general hospitals that have a lot of specialists and that are located in the capitals of the Latin American countries, they tend to be the ones that are most needed or that can offer the most help to other parts of, to other sites around the country where they don't have the specialties, they don't have the doctors or the resources. And usually the norm is to send patients from all over the country to these central hospitals, these general hospitals in the capital city. So telemedicine started like that. These general hospitals were overused and were overcrowded, and they were receiving patients from all over the country that didn't need to be there in the first time. So the idea of using telemedicine was really generated in these general hospitals that are centralized in Latin America, and they are usually related to the use case of the access to the specialist. I think that is one of the key elements. You see there, the level 3 and level 4 are the ones that are leading the pack. So this is clearly showing that the case for telemedicine is the access to specialists. And then there is a gap. There is a gap that also happens both in private and public sector hospitals in Latin America, and that gap is basically the gap of specialists. And usually, again, in some cases, the gap is not, if you analyze the total country, the gap is not really big. But if you go region or sub-region by sub-region, then the situation is extremely more complicated. And that's something that has been leading the situation that you can see in the chart, right? The other last point would be that that again, this is many of the programs have not been long-term and they don't have the systemic or the sustainability for the long run. And although they move from from grants funding or from pilots to some local programs, they are still needing to grow considerably and to move from an isolated practice to something that will be a general practice around the system.
So I think that's a great segue into the next slide. Thank you, Gustavo. What we've noticed is that hospitals with telemedicine tend to be really nearly about 3 times larger than those without. And this can be explained by the higher patient throughput of larger hospitals, as well as their ability to leverage infrastructure and investments, which can be a lot more challenging for smaller hospitals, as we discussed way earlier in the presentation. But as we look at the penetration of telemedicine and other technologies along the axis of telemedicine, so other technologies like the penetration or the presence of an EMR or patient interoperability or home monitoring or PACS or risk systems, for instance, we see that it goes above having one single element in place that drives telemedicine, but it's really a question of culture and a question of mindset. I think, Gustavo, that plays directly to your point that these 2 factors are really critical in order to develop a successful telemedicine program in the long run. You really have to have that mindset in place, and you really have to have e-health and technology as part of one of your central goals and your central visions in your strategy. And telemedicine needs to be part of that strategy. That's where we see telemedicine being very successful, when it's part of that strategy. And I think that's what you were just alluding to a moment ago.
Yeah, and I would add to that in terms of this slide, the leadership, because I think the programs that we have seen that are very successful, they have the medical leadership, but it's a strong marriage between the medical part and the technical part. It's a very strong marriage, but it has to be led by the medical part. And within the medical part, all the projects that we have seen that have been very successful were led by someone who was a visionary, a leader, someone who really motivated everybody and got everybody to work around the same objective. And also someone who showed the authorities that he or she could lead it and implement it properly. So I think leadership is one key element here, and also making it part of the medical program and priorities is the other key element here. The fact that the large hospital with a large investment in technology are more suitable for telemedicine, it speaks by itself, but also it makes technology something easier, especially now that you can adopt technology as a service, both the infrastructure and the software. So you can really deploy technology without telemedicine program, without big investments in technology. You can really adopt technologies in very easy ways and very favorable conditions in terms of economic conditions, using the cloud, using all the infrastructure as a service that is proposed by different suppliers, and also the software. You can now rent the software on a monthly basis, which is really helpful for the long-term approach and the growth of the telemedicine programs. And my final comment in this one related to the international, I think the international level or the international telemedicine encounters will be a step in the future. I think there will be a lot of regulatory situations still to, regulatory and financial issues to resolve before moving heavily into that, but it's definitely something that in the long run will play a role.
Absolutely, and I think we're going to touch upon that point of international telemedicine in just a moment. Cynthia, I'd love to get your comments on the leadership role. Let's save those just until the Q&A session, because the article that you wrote about 2 years ago in Health Affairs that was published with some of our data pointed directly to that, to the need of leadership within institutions to drive telemedicine penetration in Latin America. So let's move along. Being cognizant of time, we're almost reaching our hour deadline. We will stick around. We have about 2-3 more slides to cover and then do Q&A. So if you'd like to stick around, please do. That'd be terrific. We'd love to have you with us. Alternatively, you can also get the presentation deck by email in the next couple of days. Mariana, I'll pass it to you for, I think, our 3rd or 4th poll question. Please go ahead.
Yes, thank you, Guillaume. That is correct. This is our 3rd poll question. Based on your experience, what do hospitals most need in order to increase telemedicine usage? Training or education, IT equipment, financial models or incentives, alignment with payers, cultural shift, or better understanding of telemedicine? Let's give it a few seconds. As you were saying, Guillaume, we will be sending this presentation as well as the recording of the webinar. So you will have this more or less in 24 hours. We're getting a lot of questions. Thank you. Just for those who feel more comfortable sending them in Spanish, hablamos español. So please feel free to send them in Spanish as well. So let's give it a few seconds while it loads. And the results are back. 35% of you think that it's financial models and incentives, versus 24% think that it's cultural shift and better understanding of telemedicine, followed by training and education, and 3% IT equipment. Thank you so much for your feedback. And let's move on to the last portion of this webinar. Guillaume, go ahead, you're on mute.
Great, thank you, Mariana. And I encourage you all to stick around for the next couple slides, because really this is where we're going to be talking about the forward-lookingness of telemedicine in Latin America. So throughout the presentation, we've been talking about telemedicine as a way to augment capacity, whether this be through triage, so it's through self-screening, or for patients that that need to stay away from the hospital, or even as we were talking with Dr. Villaseñor a couple of weeks back in our first webinar in the series, about using artificial intelligence models through Q&A systems in order to be able to determine if a patient will require testing or not. Another way to augment capacity through HR. So the integration of additional medical staff into the system. So folks that don't necessarily work within the confines of a hospital system, but can really bring support in times of COVID-19. Gustavo, you were alluding to a moment ago to the resource allocation. So on one hand, we're seeing medical staff being laid off for all the elective surgeries. And on the other hand, having frontline staff really being pushed to their limits, both mentally and physically, in order to provide support for patients on the day-to-day. So integrating additional staff through telemedicine could be one way to alleviate that pressure, as well as obviously supporting the frontline staff, helping them manage their burnouts and their psychological support there. And we often talk about the frontline staff, but let's not forget also the IT staff that's behind them, that's supporting them, and all the admin staff that supports the front line that also sometimes needs some relief. From the technology standpoint, really what technology is a leverage. It's a leverage tool. So it's an ability to increase capacity in a very fluid and elastic manner in that regard. And we see in Latin America the possibility of all the spoke sites that need to access those specialists that we were just talking about. As well as collaboration between hospitals. So hospitals that have available capacity in one hand versus the ones that are under a lot of pressure on the other, as well as, Gustavo, you mentioned this also a bit earlier, in the future, the possibility of regional collaboration within hospitals. In the case of Mexico specifically, there's an infrastructure issue where there's multiple public sector models operating under the same roof, all under the public sector, whether it's IMSS, ISSSTE, SEMAR, SEDENA, PEMEX, or others. Those are all public system models that could be better articulated, even then also considering the integration and collaboration of private sector models. Okay, let's move on to the next slide. So before we move into our Q&A session, we're just going to wrap up this presentation. I'm going to open it up to both Cynthia and Gustavo in just a second. And we're going to wrap up with just a review of some of the challenges and some of the opportunities that we see here in the context of telemedicine, specifically in regard to COVID-19. First of all, I think it's fair to say that progress in telemedicine in Latin America has been slower than what was expected. But at the same time, COVID-19 and this current pandemic could really be a catalyst for broader changes in healthcare to happen more rapidly, to be implemented faster. Another group of challenges that we've seen is the lack of a long-term approach and strategy for sustainability of telemedicine programs, the lack of regulatory framework, as was mentioned, the lack of incentives, and the lack of alignment between the current care models. What we're seeing happen in parallel to that is we're seeing an incursion of tech companies that are outside of the realm of healthcare, but that are going through the healthcare space, such as Microsoft, Google, and Apple, that could very well be disruptors of that space moving forward. A third bucket of challenges that we're seeing is the fear of change, and that was alluded to earlier from physicians, from payers, and from patients in terms of using this technology. The HR supply, so the supply of physicians that are able to care for patients in this case, and the alignment of political and medical goals. Now, we have to remember in all of this that amidst all of these challenges, what telemedicine can really help us do is meet the future demand for healthcare. In this current context, we're talking about a pandemic, we're talking about COVID-19, but in Latin America, we have to also think beyond COVID-19 and talk about the aging population and the ability to manage chronic diseases, for example, as well as offering equitable care amongst socioeconomic levels. So we really need to prepare for all of that and prepare for future eventualities that are right around the corner. So it's a manner to leverage, to scale, and to augment care capacity. And so on that note, I'll gladly turn it over to you, Cynthia, to get your thoughts and comments on what's the future of telemedicine, what's the future of healthcare with telemedicine in it.
Well, I think that's the bigger question, is that at least in the United States, in a number of different task force and think tanks that I'm involved with, is that there's going to be a new normal when it comes to healthcare. And some people are starting to think about what that new normal is, and telemedicine is definitely part of it. And I think one thing that we have to understand, even if you're facing the mist of COVID, this is not a silver bullet panacea type of situation. Right now, providers that are having to turn over and with perhaps an hour's worth of training, move into becoming telemedicine distance-based providers, there's a difference in the way that you do this. There's a quality encounter, and then there's an encounter that's not going to be as successful. And when you're in situations where it's an hour's worth of training, all of a sudden you're a telemedicine provider, that's not an ideal situation. So we want to come back to, in light of things, in light of having so many people flip the switch on different types of telemedicine encounters out of necessity at this particular point in time, take those lessons learned and then conceive of a new normal where if we're in a more normal-sized routine, quote unquote, point in time, what do we take from this experience? Where's the innovation? Where's the creativity? What have we learned? What are the possibilities? And how do we move that forward? And one thing when it comes to, in terms of who moves that forward, historically in telemedicine, it's been a matter of champions. A statement was made earlier about basically having the clinical side. Well, specifically a clinical champion. And in terms of saying leadership or what have you, sometimes it all aligns, sometimes champions is a little something else. And it's not just the champion at the hub site, but research work that we've done clearly shows that you need a champion, clinical champion, at both the hub and the spoke site. So if you're looking forward to a new normal, and what this all means is know that this is a painful time in terms of the way we're having to implement telemedicine. take the lessons learned, realize that there are some visions that we can have going forward, and identifying some of those champions that can help us shape that vision and what would it look like to really leverage and utilize and optimize this tool in the toolbox of healthcare.
What brilliant expression of the current context. Thank you, Cynthia. Gustavo, on your end, how do you see some of the challenges and some of the opportunities that are ahead for both Cisco and telemedicine at large?
I would say that this time is unique, and we have to take advantage of this situation. We have to really, avoid all the barriers that we had in the past to make this, a regular way of doing medicine. I think it's the right time, it's the right combination of technology and medical components. The technology is now cheaper than ever before. It requires lower connectivity levels than ever before. It's offered as a service that didn't happen before. So I think there are many, many situations from the technology point of view that are very, very positive for really the launching telemedicine in a big way. As every innovation, implementation in the history of technology, this is a process, and it will take time, and you will need to be a champion of change. These champions that Cynthia was mentioning, and I agree 100% with that, are also leaders in change. They are people that will bring people together, that will overcome fears, and that will help the institutions to really move fast and implement this. The risk of the situation, the current situation, is that we do something at speed light, at full speed, and we try to overcome some of the needs immediately, and we do it wrong, and we don't do it properly, and we end up having a negative experience that will not allow telemedicine to grow. My final comment is I have seen, and I have been working for the last 10 years in telemedicine in Latin America, and I think situations like this one are really moving the issue to a top priority in the agenda. And this is extremely important. It wasn't a top priority before. It was always something that nice to have, we have to have it, we have to move it to the future, but it was always postponed for some reason. I think now this is showing that it doesn't need to be postponed, that you really need to implement and start, because it's a process. It will take time to mature. So you need to start now and make sure that the next pandemic, you will be ready and you will be using telemedicine in its full capacity.
Terrific. Thank you, Gustavo, for that insight. I'm now going to turn it over to Mariana, who's going to kick off our Q&A session.
Thank you, Guillaume. Now, before we do go to the Q&A session, I just want to give you a little bit of information in terms of the 4 unique services that I mentioned at the beginning of the webinar. As I mentioned as well, things are changing very fast every day. So we're kind of navigating with a lot of fog, and I feel there's a lot of uncertainty going on. So we are the go-to company for everything related to healthcare. We are pioneers in terms of gathering hospital data, and we have these 4 services that can help you. So please don't hesitate to reach out to us for anything you need. We have the world's only and largest hospital demographic database focused in Latin America. We have a database of procedure volumes as well, which is quite unique. We also have the opportunity to do market size and market share by analyzing import data, and this is very precise, and it's a great tool as well. And lastly, given the more than 20 years experience that we have conducting market research and market intelligence, we have a wide array of experience in this for any very specific or granular needs or questions that you may have. We can help you with all of your ad hoc needs within scope. So again, these 4 unique services for you to help you, to guide you through these difficult moments. So keep that in mind. Now, I'm gonna open up the Q&A session with a question for Cynthia. It's something that we've discussed already, but we've had this question many times. Can you really do quality care via telemedicine?
I think you can, and a big part of it is knowing the boundaries and what's capable and what you can do via distance. Guillaume said he had a problem with his eye, and he basically had this encounter with a teleophthalmologist. There are certain things that can be done via distance and certain things that can be not. Now, that being said, say we get that situation where we have set those parameters, we have the appropriate medical protocols on basically clinically what can be done. Well, underneath that, it's also a matter of we have to have technology that's reliable and that works with us. In this particular case in time, a lot of people are using video. Some of those calls are great and they work really well, and some of them we have technical difficulties. That's one aspect that once we have, here's the rules to provide quality care. Here's the rules when it's appropriate to give, for example, an antibiotic or some other type of medication in telemedicine. We also have to think about that. We have to think about the patient understanding that when they come into the exam, what's possible, what's not possible, and setting appropriate expectations from the patient side too and what's happening. And we also have to think, so letting the patient know, for example, in terms of focus groups and things that I've done, is patient walks into a room and they're expecting to see, they're at a clinic that's in a remote location, expecting to see a face-to-face provider, and they see somebody on a screen, you know, there's a first jolt. And if that communication process is going, we might as well close up and go home because it's not going to happen. So we have to think about setting the patient expectation. We also have to think about the provider in terms of during the exam. Some providers are going to be better at this than others, just like some people in even this type of presentation are going to be better to have that online presence and establish that rapport that so many patients look for in certain situations than others. So there's a lot of variables and there's a lot of different levels in terms of the quote unquote quality exam. And the first place to start is really what can we realistically do in a medically sound way in this particular context, and then we start thinking about all those other factors to make it a really nice quality top-notch exam following those medical guidelines.
Absolutely. Thank you very much, Cynthia. Guillaume, would you like to add something?
I think that's a very good point. I have seen through some of these questions that are coming in. And by the way, thank you all for being so active online and sending your questions through. We've have over 100 questions here today. 43 of them and counting are still adding up. But some of them are pertaining to the quality of care between the public and the private sector, especially as it pertains to telemedicine. We have to remember that some of Latin American hospitals are extremely qualified when it comes to giving care, both on the public as well as on the private sector side. One that comes to mind immediately is the Albert Einstein Hospital in Sao Paulo, which recently ranked 37th in the world for quality of care. So granted, that's a private hospital, but there are also several highly specialized public institutions that deliver very high quality care on a day-to-day. Now the question is, how does that transform into telemedicine, and how do the systems integrate in order to be able to transmit that to patients as they're going their teleconsultations, their store and share models, etc. So just something to keep in mind, that there is some very good care being given through Latin America today, and it's a question of transitioning that to Latin America. Thank you, Mariana.
Thanks, Guillaume. Gustavo, I don't know if you want to add something in terms of the quality of telemedicine.
Yeah, I would reinforce the point from Guillaume about the quality of our hospitals in Latin America. We have many hospitals in Latin America that are Joint Commission certified, which is something very important. It's an international certification that really demonstrates that the quality and safety of the patient is being managed at the top level. And I would also say that there has been a lot of research on the quality and the satisfaction of the patient, satisfaction of the doctors and the family of the patient, and we haven't seen any negative response to that. All the research that has been done has been extremely positive. And in my personal opinion, I think the patients are more ready than the institutions and the doctors. I think the patients are looking for it. They are waiting for it. They are, as Guillaume said, he took teleconsultation last week. I took two, one for my daughter, one for me this week. I think we are ready. We are using the connectivity, the video solutions for everything in our day-to-day life, and the medical services should be another one that really provides this. So again, I think the public and the patients are ready.
Thank you, Gustavo. On that note, we have a specific question for you. Given your experience in telemedicine, what is, in your opinion, the key factors for a telemedicine program to be successful in Latin America?
Wow. Well, again, I think we mentioned a few things, and Cynthia mentioned some of them that we really share in between us that are really important. But I think the most important one is the leadership. All the programs that I have seen that are successful they have a very great leader, someone who really is a visionary and is a change agent. Is someone who can really give support to people implementing and also give confidence to the people funding it and making the decisions. So the leadership is critical, and it has to be a medical leader. Definitely, it's not a technology leader. It has to be a doctor. It has to be someone from the clinical environment. Then the other one is the support of the decision makers and senior management in the organization, namely public sector like ministers or a director of a clinic or a hospital. The senior management has to have this in the top of the agenda and has to be backing the program and the person in charge of the program. Then the other point that is probably important, but it's really difficult, is the business model around the implementation of the telemedicine. The business model has to click nicely with the current business and operational model, if you want, and the financial model. If you don't get that, it's going to crash. It's going to be very difficult for telemedicine to be adopted. So you need to have a smooth integration between the current model, financial and operational, with the telemedicine model. That's another one that I think is extremely important. The other one that I've seen, and I think is also extremely important, is the implementation of a change management program. This is reinforcing the idea of the leader, but you have to have a program that has also incentives and it's being administered properly so that you can really generate the change you need and use all the techniques of change management that are extremely required or needed here in telemedicine. Finally, two more points is one, I think the components of the program need to be wide. You cannot isolate telemedicine to clinical interactions. You have to also include the continuing medical education. You have to include the administrative coordination and logistics and operations. So once you have the infrastructure and the technology in place, you will use it. Not only 60% or 70% of the usage will be clinical, but you have to have the rest also up and running. And you have to do it with a multidisciplinary team. You have to have people engaged from administration, from operations, from logistics, from management. So again, this has to be an overall approach with a very solid model of operations and financing. And finally, one comment from technology, which is everybody thinks telemedicine is just a video solution. And we differ with that because we think it's a lot more than the video solution. You need software to automatize and escalate. You have to digital transform the entire process. You have to review the process and sometimes redesign the process. So there are a lot of components that are beyond the video solution that you have to consider. I think these are the top that are coming to my mind.
Thank you.
Mariana, one quick comment to that is sometimes I've seen telemedicine programs done on a shoestring, because you hear all these things that were just said. It's like, wow, this is so much and so overwhelming. Is sometimes when there's just a need and a really important situation, we have to keep it as simple as some of this is not new. We've been in situations before where we just pick up the phone and talk to a provider. So, there's the big telemedicine program, and there's sometimes where it's just sometimes you can't be there in person, and you'd be surprised at times what could be done on a shoestring.
That's exactly true, Cynthia. And I would add to that my experience also is that the programs that have been successful have been done in phases, and progressive and growing phases, but usually starting small and growing from there.
Perfect. Thank you very much, Gustavo. We have a question from Diego Mora in the audience for Cynthia. How can telemedicine and home hospitalization benefit from each other?
So so some of that's giving an example of what do you mean by home hospitalization? Are you talking about home monitoring? And then really and truly, we're not talking about something different. As Guillaume pointed out in the presentation, pointed out earlier on, is there's you know, in the whole field of telehealth, there's things where perhaps you don't, there's just this where there's not a provider on the other end per se on that real-time type of basis. We have different types of institutions now talking about the comment of a home and the idea and concept of a home hospital and what does that look like. And some of what that looks like we already see in terms of what can be done at home. There's a lot of types of peripheral equipment that can go with the telecommunications. You can have, for example, an otoscope at home. You can have a Bluetooth stethoscope. You can have all of those sorts of things. The question is really when you're conceiving is what does technology have to offer? What is available at home to the patient? What's going to be affordable in that situation? And what can that particular patient and the caregivers around them have the capacity to take on and that they're willing to take on in terms of having a more active role? Because essentially in some ways that's what we're talking about, a more active role in the care process if we're talking at them not being in a clinic or being in a hospital.
Absolutely. Thank you very much, Cynthia. We also have a question from Eduardo Vega in the audience for Gustavo. Please name the top telemedicine companies in Mexico and Latin America.
That is a tough one. I think that goes to the model of telemedicine in Latin America compared to the US. I think in the US you have 4 big companies that are basically the leaders in telemedicine. One is Teladoc, the other one is American Well, the other is MD Live, and I think I'm missing a couple more. But usually, what happened in the US was that after a big debate and many years of development, the model has been established as the third party who is providing the technology enablement and some parts of the medical enablement to do telemedicine. So you see United Healthcare using American Well, or you see Baptist using American Well, or someone else using Teladoc, but also they provide direct services to the patient. They connect the doctor with the patient directly, the doctor who has his own practice, which really works here in the US because that allows the doctors and the institutions and the patients to interact properly, and also the insurance company are coming to the play right now. In Latin America, we don't see that model. The model is mostly driven by institutions and usually by public sector institutions, and it's basically a model in which they buy some technology, but they don't rely on a third party to implement the entire process. They basically buy the technology to connect their own hospitals, the central hospital in the capital of the country and the remote hospital. So there are some companies like Cisco that are providing technology to do that in Latin America. And I would say the top are Cisco, Zoom, of course, which is a competitor of Cisco, at least in the software part. Cisco has a full collaboration suite that includes hardware and software, which is very important for telemedicine, because in the case of hospitals, you need, for example, solid hardware video units for the doctors to be able to really interact properly, which is a little different than the webinar, no? So technology, again, I haven't seen many companies. I have seen a lot of startups, small companies in Latin America working, not many big ones. And to be honest, again, it's more a technology play in Latin America than a telemedicine play or telemedicine company play.
Perfect. Thank you very much, Gustavo. Guillaume, is there something else you'd like to add?
No, just that we've had a lot of questions surrounding the regulatory framework across countries. We are close to about 100 questions being posed online as we speak. All sorts of different sectors and all sorts of backgrounds of these questions. We will try to answer them to the best of our ability, knowing that some of them might require some research. So we'll get back to the respondents on that. I want to just extend my tremendous gratitude and thanks to both Gustavo and Cynthia, who've taken time out of their extremely busy schedules in light of the whole COVID situation to be able to talk to us about telemedicine here today, and to all the audience members who have participated and actively sent their questions through. So thank you, everyone. I'll pass it back to you, Mariana.
Thank you, Guillaume. Thank you, Cynthia. Thank you, Gustavo. And thank you, everyone, for attending today. Be on the lookout. We will have more webinars coming your way. In terms of this one, as I mentioned many times before, we will be sending the presentation and the recording. So it'll take us more or less 24 hours. Thank you again. Keep safe, keep healthy, and we'll be in touch. Take care.